Very good afternoon to one and all. I'm Dr. Sidra Ansari, and in this session, I'm going to discuss about osteomyelitis and osteoradionecrosis of the jawbone. Now, osteon is nothing but bone, myelion is marrow, and itis is inflammation in Greek. Thus, osteomyelitis may be defined as an inflammatory condition of the bone that begin as an infection of the medullary cavity and the Haversian system, which spread to the cortex and extend into the periosteum of the affected area. Now, the predisposing factors for this is the host resistance, the jaw vascularity and virulency of microorganism. Now, factors that will affect the host resistance are the varied metabolic conditions like malnutrition, diabetes, severe anemia, osteoporosis, fibrous dysplasia, Paget's disease, leukemia, then steroid patients on long-term steroid, cancer and AIDS. Then decreased vascularity. Decreased vascularity, if you compare the maxilla and the mandible, maxilla is comparatively highly vascularized than mandible. And as age advances, the vascularity of the mandible further decreases. It is supplied by the inferior alveolar artery in the centripetal direction and the periosteum in the centrifugal direction. So if you see that as the blood vascularity decreases, the immune cells cannot reach the target area in the adequate manner, and this will facilitate growth and spread of microorganism and result in establishment and progression of osteomyelitis. Thus, osteomyelitis of the mandible is more common compared to the maxilla. Then come the virulency of microorganism. Initially, it was said that it is caused by staphylococcal infection, but later on it was seen that it is mainly because of mixed infection, both gram-negative, positive and anaerobes. That includes streptococci viridans, gram-negative like Klebsiella, Pseudomonas, Proteus, anaerobics like Bacteroid, Peptostreptococcus organism. Now, the etiology of osteomyelitis is basically because of either local infection or because of hematogenous spread. In maxillofacial region, it is more commonly because of a local existing infection, that is odontogenic infection. Or it could be because of the trauma that has compound fracture which has communication with the exterior, or lymph node infection with furuncle and lacerations. Now, let's move on to the pathogenesis of osteomyelitis. In case of acute inflammation, there is edema and accumulation of pus. Now, this increases the intermedullary pressure, which eventually causes vascular collapse, that is stasis and ischemia of the bone, resulting in an avascular bone. Now, in this avascular bone, the pus will become to organize and spread through the Haversian system and the nutrient canal. Eventually, it causes elevation of the periosteum, which further disrupt the blood supply to the bone and avascular infection of the bone. Now, there are certain terminologies that you need to understand before we proceed further. One is sequestra. Now, as the infection or the inflammatory process subsides, there is granulation tissue formation, and which eventually try to separate the necrotic bone away from the viable bone. Now, this is termed as sequestra. Then, involucrum is nothing but large isolated necrotic bone surrounded by granulation tissue and encased in new bone. Okay, cloaca. Cloaca is nothing but channels that are coming out of involucrum onto the exterior of the surface. Topazian has classified osteomyelitis into suppurative osteomyelitis and non-suppurative osteomyelitis. Suppurative osteomyelitis further have acute suppurative osteomyelitis, chronic suppurative osteomyelitis. Chronic can either be primary or secondary, and infantile osteomyelitis. Non-suppurative osteomyelitis is diffuse sclerosing osteomyelitis, focal sclerosing osteomyelitis, proliferative periostitis, that is Gary's osteomyelitis, and osteoradionecrosis. Let's move on to the clinical features of each of these varieties. We begin with acute suppurative osteomyelitis. As the name suggests, the condition is acute, associated with deep, intense pain. Patient may have intermittent fever. There will be localized swelling or edema, or because of the formation of pus. Eventually will spread of the pus into the muscle, result in trismus. There is regional lymphadenopathy, Vincent symptoms. It is nothing but paresthesia or anesthesia of the lower lip because of infection hampering the inferior alveolar nerve. The patient may be dehydrated. In the initial phase of acute osteomyelitis, teeth are not mobile, swelling is minimal and fistula is not present. But if it is not treated within 10 to 14 days of onset, then it progresses into subacute suppurative osteomyelitis. Here the pus may try to spread from the Haversian system, to the and try to lift the periosteum and exudate around the gingival sulcus and the mucosa. There will be presence of a mucosal fistula or a cutaneous fistula. There is presence of phytororis because of the anaerobic bacteria. The tooth is mobile and POP is positive and mental nerve paresthesia is present. If this condition is not controlled, this will result in secondary chronic suppurative osteomyelitis, wherein there is frank pus formation, mucosal cutaneous fistula, induration of soft tissue, woody characteristics of the bone, dull pain and tenderness on palpation, and formation of sequestra. Let's move on to the clinical characteristics of primary chronic suppurative osteomyelitis. As the name suggests, it does not precede an acute symptom. It is insidious in onset. Because of a low-grade infection for a longer time, we are not able to treat it, result in primary chronic suppurative osteomyelitis. Here the pain is comparatively less than the acute symptoms. It is a slow-growing swelling of the jaw. There is gradual development of sequestration, often without fistula. Now, other types of osteomyelitis. Infantile osteomyelitis. It is a very rare condition seen in infant. It occurs because of the perinatal injury to the oral mucosa, wherein the obstetricians try to remove any kind of blood clot, with the finger, or use a rubber suction to remove any kind of blood clot after the delivery. That can result in injury to the mucous membrane, or by using contaminated nipples. Now, the general constitutional manifestation is you have pyrexia, anorexia, vomiting, constipation. Then clinically there will be facial swelling which is centered over the orbit. There is inner and outer canthal swelling, conjunctivitis and proptosis. Then intraorally the maxilla is affected, that is swollen both buccally and palatine, and there will be presence of a fistula. This condition affects the maxilla rather than the mandible. Now move on to the proliferative periostitis. It is also termed as Gary's osteomyelitis. It basically occurs in children and younger adult. It is clinically seen as a gradual swelling. The skin overlying the swelling is normal. There is no lymphadenopathy, no fever, no leukocytosis. There is no pain. It is commonly associated with a carious tooth, that is more commonly lower first molar. The tooth was carious. Initially there was pain, but as the pain subsided, the treatment was not done for that case. So it's actually body response towards infection in form of caries osteomyelitis. On the OPG, you will see a periapical infection associated with the primary molar, and there will be marked periostal reaction along the inferior border. On the occlusal radiograph, you will see subperiosteal new bone formation resulting in an onion skin appearance. It's basically body response towards the infection. Now, Gary's osteomyelitis may mimic Ewing sarcoma, osteosarcoma, chondrohyperostosis, or Caffey's disease. But you need to keep in mind that Ewing sarcoma have a sundry appearance. The periostal reaction is not present in Ewing sarcoma. Osteosarcoma also have a sundry appearance. Whereas Caffey's disease, it is seen in the angle and ramus region, not in the body of the mandible. And it is not associated with the carious tooth. Whereas Gary's osteomyelitis, there will always be a definite dental cause. After dental treatment, the lesion will eventually subside. Now, let's move on to the chronic diffuse sclerosing osteomyelitis. It is an inflammatory, non-suppurative, painful disease. It occurs in the mandible and affects both the basal as well as the alveolar process. It is seen in third decade of life. More commonly, females are affected than the males. Here, fever and lymphocytosis is not present. ESR is increased. Mark state that it is mainly because of bacterial infection, that is by Escherichia coli, actinomycosis, bacteroids. Now, on the radiograph, you will see a mixed radiolucent and radioopaque lesion because of diffuse intramedullary sclerosis of poorly defined margin. Now, it may mimic Paget's disease or osteoporosis and fibrous dysplasia. But you need to keep in mind that in case of osteoporosis and Paget's disease, other bones are also affected. But in case of diffuse osteomyelitis, only one bone is affected, and in fibrous dysplasia, you will have a typical ground glass appearance. Let's move on to the chronic focal sclerosing osteomyelitis, also termed as condensing osteitis. This condition is more commonly seen by an endodontist. Okay, why? Because it's nothing but a localized area of bone sclerosis associated with the apex of a carious tooth with periapical periodontitis. So if you can restore the teeth, do an endodontic treatment. If you cannot restore the teeth, extract it. Now once you have treated the cause, the lesion will regress in size and remain as a bone scar. Now, investigations that you need to do in case of osteomyelitis is routine blood investigations, radiograph, blood culture and antibiotic sensitivity to start with your antibiotics, and histopathological examination for your final diagnosis. Now, in case of acute osteomyelitis, in your blood culture, you will see, that is blood investigations, you will see mild to moderate lymphocytosis. There will be low HP and there will be slightly elevated ESR level. But in case of chronic osteomyelitis, laboratory findings seems to be normal. On the radiograph, there will be scattered area of bone destruction. Okay, that is termed as motte-eaten appearance, mixed area of radioopacity and radiodensity. Okay, you will see islands of radioopaque area, that is sequestra. There is a stipple or glandular differences, subperiosteal deposition of new bone. Okay, can be seen on the occlusal radiograph. Now, Kazunora Yoshida classified mandibular osteomyelitis into 4 basic patterns depending upon their radiographic feature as lytic, sclerotic, mix and sequestrum pattern. Let's move on to the treatment modalities of osteomyelitis. Can be broadly divided into conservative management and surgical management. In conservative management, ask the patient to have bed rest, supportive therapy like good nutrition, hydrate the patient, blood transfusion if required, control of pain, start with IV antibiotics, and if required, do hyperbaric oxygen therapy. Surgical management include extraction of the offending tooth, incision and drainage, then continuous intermittent that is use of irrigation, sequestrum, saucerization, resection and reconstruction. Now we start with the conservative management, that is the empirical antibiotic. Now these are basically based on the gram-negative staining result from the exudate or the suspected pathogen likely to be involved in the maxillofacial region. When a patient comes to you with an osteomyelitis, you don't know what type of organism is there, but you have to start with an antibiotic. In that case, you will start with a broad spectrum empirical antibiotic, take out the specimen, send for culture and sensitivity. Now, this culture and sensitivity will give you a definitive antibiotic. Then you will replace this definitive antibiotic from the empirical antibiotic. Okay. Then, once you get a culture and sensitivity, you start with your proper antibiotic regime. Now, regime 1 is for hospitalized patient. Okay. You start with aqueous penicillin 2, that is unit 4 hourly, plus metronidazole 500 milligram 6 hourly. Okay, if the condition improve after 48 to 72 hours, then you will shift the IV to oral, that is penicillin V 500 milligram orally, metronidazole 400 milligram orally for 4 to 6 weeks. Okay, now if the patient is allergic to penicillin, you will give ampicillin plus sulbactam 1.5 to 3 grams IV 6 hourly. If the condition improve after 48 to 72 hours, then shift to oral amoxicillin plus clavulanate, that is 875 to 125 milligram 2 times a day for 4 to 6 weeks. Now, if the patient is on outpatient basis, you will give penicillin V plus metronidazole 0.5 milligram 8 hourly orally for 2 to 4 days. Okay. If the patient is resistant to this, then you will, or allergic to this, you will give clindamycin. If the patient is resistant to clindamycin, you will give cefotaxime or cephalexin. Now, the recent antibiotic that are used are moxifloxacin. Okay, it is a 4th generation fluoroquinolone. Now, it is effective against oral streptococci anaerobes, especially against Echarella corrodens, which is resistance to clindamycin. Its advantage is that it has good oral absorption and high penetration in the bone, and it is used in case of refractory osteomyelitis. The other recent advancement in the drug is linezolid. These are synthetic antibiotics. They are used in nosocomial pneumonia and skin infection. Now it basically inhibits 50S ribosomal subunit and interfere with the protein synthesis in the bacteria. It has 100% bioavailability after oral administration, and it has a very good penetration into the bone. Now basically these linezolid are used in drug-resistant pathogens and when glycoprotein administration is not possible. Okay, nowadays the bacteria have developed resistance to vancomycin. So if there is resistance to vancomycin, you could opt for linezolid. These are available in form of tablets, 600 milligram only. Then local antibiotic therapy. Now this is based upon the principle wherein you deliver the antibiotic at the site of the infection so that you will decrease the systemic toxicity, at the same time you increase the therapeutic rate. Now this can be done by using a closed wound irrigation and suction. Now tubes are placed against the bone to allow drainage of the pus. Okay, at the same time another tube is placed to irrigate it. Now here you will take an intraoral incision, do a thorough debridement, saucerization, decortication. Okay, small pediatric nasogastric feeding tube per tube are used, which is around 3 to 4 millimeter in diameter, 6 to 10 inches in length, and perforated along a distance of 3 to 4 millimeter from the tip. These tubes are placed into the bony bed through separate skin incision and they are fixed. One tube is used to irrigate the solution and add the antibiotic, whereas the other tube is used to suck it out. Okay, here 2 liters of solution is given into the cavity and is evacuated from the cavity from a period of 24 hours. Now culture is performed after every cycle, okay, continuously after 1 week until 3 successive cultures are sterile. Now antibiotic that you can use in this case is clindamycin you could use, bacitracin plus neomycin plus polymyxin you can use, neomycin plus polymyxin in equal volume can be used. Normal saline solution can be used. Okay, you will inject the antibiotic, let it stay in the bone defect for 3 hours, and over a period of 9 hours with an intermittent slow suction you will suck the antibiotic out. You will do this for 12, it is a 12-hour cycle, and then you will repeatedly take a culture unless your 3 successive culture are sterile. Okay, now things that you need to keep in mind is that wound should not be overfilled. Okay, the volume should be gradually decreasing for the healing to take place by secondary intention, and a systemic antibiotic should always be continued. Then antibiotic impregnated bead. Okay, now this is based on the principle that you are giving high local level of antibiotic are made available and overall systemic doses decrease. Okay, it is used in chronic sclerosing osteomyelitis which are refractory to systemic antibiotic. Now initially gentamicin polymethyl methacrylate was used, but nowadays tobramycin, amikacin, augmentin, clindamycin are also used. But you need to keep in mind that the antibiotic you are selecting should be water soluble, should be in powder form, and should resist heat, because during polymerization heat is generated. So it should not deteriorate at that time. And you need to place for 10 to 14 days and then remove it from a separate incision. Let's move on to the surgical management of osteomyelitis. The basic surgical procedure is sequestrectomy, wherein you remove the sequestrum, that is the dead bone. Now this dead bone can either be cortical bone or corticocancellous bone. It is basically avascular, and that's the reason why you need to remove it, because it is avascular. Because of avascularity, antibiotic cannot penetrate it. And since antibiotic cannot penetrate it, it acts as a nutritive media for the microorganism to spread. That's the reason why we need to remove it. Okay, this method will prevent the infection and minimize the tooth loss and bone loss. The next is saucerization. It is nothing but unroofing the bony cavity to expose the medullary cavity for thorough debridement. The margins of the bone overlying the focus of osteomyelitis are excised, allowing thorough visualization of sequestrum and excision of the affected bone. Then comes decortication. Decortication is nothing but removal of chronically infected cortical plates. Here, the lateral and inferior cortical plates are removed 1 to 2 centimeter beyond the affected area. Okay, it is used as initial treatment of primary and secondary chronic osteomyelitis where conservative treatment has failed. In that case, this will be your last resort. Then resection and reconstruction. Now resection are done when you see on the radiograph there is segmental destruction is seen. Okay, only after debridement is thoroughly performed, any kind of previous conservative therapy or surgical therapy cannot be done, then you will opt for resection. Okay, now after resection you could immediately do a reconstruction with a reconstruction plate, or you could wait for some time and then do bone graftings. Okay, Marx has given a two-stage protocol wherein he states that you will reconstruct the bone after 3 months of debridement. Okay, you do debridement for successful treatment of advanced acute secondary chronic osteomyelitis. Smaller defect you address from the oral cavity, larger defect from the extraoral region. Okay, you will remove the bone and then you will use a reconstruction plate to reconstruct the mandible, and later after 3 months you will do a bone grafting and reconstruct it. Thus, to summarize, clinical experience of the surgeon, clinical signs and symptoms of the presenting condition aided with the radiograph will result in early diagnosis of osteomyelitis. Now, once you have diagnosed the osteomyelitis, surgical intervention will enable the surgeon to harvest the material for histopathological examination and bacterial identification. Once we have done this, we can start with an specific antibiotic for that specific microorganism, and then take a series radiograph to monitor the response of the patient to treatment and to help determine the end point of the treatment. Now let's move on to osteoradionecrosis. Now, by definition, osteoradionecrosis is an exposure of non-viable, non-healing, non-septic lesion in an irradiated bone which failed to heal without intervention. It occurs in irradiated bone because of tissue injury, because of three things: hypocellularity, hypovascularity, and hypoxia. Now, it is more commonly seen in the mandible, that is around 90%. Now, this is because of the more mechanical stresses are exposed to the mandible. There is intramedullary blood supply to the mandible is less, and perimandibular tumors are more compared to the maxilla. That's the reason why it is more commonly seen in the mandible. Then the 39% of the cases are insidious, whereas 61% cases are after trauma, and that too out of that 61, 84 is because of tooth extraction, 12 is biopsy, and 1 is because of denture irritation. Now, radiation dose also play a very important role in causing osteoradionecrosis. It is said that radiation exposure below 50 curie does not causes any problem. If it is more than 60 and below 70 curie, it can cause osteoradionecrosis. But if it is more than 75 curie, then the chances increases to 10 times. Then the time period of irradiation and development of osteoradionecrosis is between 7 to 20 years. Now, Marx has put forward a 3H principle that result in osteoradionecrosis: hypocellularity, hypovascularity, and hypoxia. Osteoradionecrosis is not a primary infection of the bone. Rather, it is a complex metabolic and tissue histosis deficiency, that is tissue hemostatic deficiency. Okay. Histologically, you will see endarteritis, thrombosis, hypovascularity, cell loss, hyperemia, and progressive fibrosis. So this flow chart just summarized that because of radiation, 3H principle occur, because of which tissue breakdown occur, the tissue doesn't heal, and the demand exceeds the supply. Okay, there is an imbalance of osteocyte and osteoblast. The fibroblast total cellular depletion occur. There is decreased activity of production and decreased blood flow towards the Hevosian system. Means there is destruction that is happening, but restoration of the bone doesn't take place. Okay, because of decrease in the cells, decrease in the cell, decrease in the blood supply, decrease in the oxygen level. So the demand increases, but the supply decreases, which eventually result in osteoradionecrosis. Now, clinically, the patient will experience pain. There will be exposure of the bone, which is grey and yellow in color. There is trismus, phytororis, elevated temperature, intraoral and extraoral fistula may be present. And if the bone is destructed because of the pathology, then pathological fracture can occur. It is associated with severe pain. On the radiograph, the investigation that you need to do is radiographs you can do. You can do a CT scan, you can do an MRI scan, or nuclear isotope technetium-99 methylene, that is bone scan, which will tell you that the lesion is active or it has subsided. Now prevention, how do we prevent it? Who play a major role? Whether patient, surgeon or oncologist? None of them. All of them together play a very important role. Okay, all of them are responsible for osteoradionecrosis. Now, pre-surgically, you need to do a thorough oral prophylaxis by scaling and polishing and irrigation. Okay, infected non-vital tooth which cannot be restored, should be extracted. Infected non-vital tooth which can be restored, endodontic treatment should be done. Periodontal condition should be corrected. Sharp bony margin should be removed. Restoration, if there is any kind of decay in the tooth, restore it. Use fluorides. Okay, prophylactic hyperbaric oxygen therapy should be given. Now, surgically, when you're doing any kind of resection of the tumor, try to preserve the periosteum. Then close the tissue in layers with adequate blood supply and do mandibular osteotomy always in the midline. Now, the things that and oncoradiologists should keep in mind is that keep the exposure to lowest dose as possible. Do a CT guided irradiation so that the specific area is targeted. Use ultra potential radiation source or use brachytherapy. Brachytherapy is nothing but you insert radioactive beads or in and around the tumor so that the radiation is concentrated to that affected part and the other normal tissues are prevented. Now the patient duty is to maintain proper oral hygiene, maintain healthy periodontium, regular flossing, fluoride, use chlorhexidine mouthwash for oral maintenance. Now the treatment of osteoradionecrosis: conservative treatment, ultrasound therapy, surgical and hyperbaric oxygen therapy. Now the goal of treatment is to remove the necrotic bone and promote vascularity. Now conservative treatment, initially you control the infection, do irrigation, remove the sequestrum, exposed bone should be debride and pack it with zinc oxide and neomycin. Okay, you could also drill hole into the lingual cortical plate to encourage revascularization. From the necrotic bone, you will pass your drill towards the viable bone so that the blood supply from the normal viable bone come into the necrotic bone and which will increase neovascularization. Ultrasound therapy was first reported in 1940. It promoted neovascularization and neocellularity. Reher introduced a regime of 45 kHz of continuous wave with intensity of 27 to 39 microwatt per centimeter square. But nowadays a protocol of 40 to 50 kHz for 10 minutes is used per session. Now this increases the fibroblast and osteoblast proliferation, which eventually causes collagen production, stimulate growth of the blood vessels and a deeper bone penetration takes place. Now, when do we need to do surgical resection? When there is presence of an osteocutaneous fistula, there is presence of a pathological fracture, or segmental bone resorption has occurred on the radiograph, or wherein hyperbaric oxygen therapy is not successful. In that case, you have to do a bony resection. Now, what exactly is hyperbaric oxygen therapy? It is a mode of medical treatment in which the patient is entered into an enclosed in a pressure chamber and breathe 100% oxygen at a pressure greater than atmospheric pressure. Now, it is based upon the philosophy that oxygen combined with hemoglobin and it is 95% saturated. At a higher pressure, more amount of oxygen is dissolved in the hemoglobin and more amount of saturation is achieved. Now, its therapeutic effect is that it restores the function of WBC. It has a bactericidal and bacteriostatic effect. It causes neovascularization. It augments the capillary growth and fibroblast and aid in proliferation and granulation tissue formation. Now, the other uses of hyperbaric oxygen therapy is it can be used in refractory osteomyelitis, necrotizing soft tissue disease, crush injuries, thermal burn, air embolism, carbon monoxide poisoning and neurological illness. Now, contraindication of HBO therapy is untreated pneumothorax, severe asthma, emphysema, previous year surgery, upper respiratory tract infection, optic neuritis, immunosuppressive disorder, and patients who are claustrophobic. Now this is the monoplanar chamber wherein single person gets the 100% oxygen above the atmospheric pressure. This is a multiplanar chamber wherein a multiple people can sit inside. Marx in the University of Miami has produced a protocol for treating osteoradionecrosis. Okay, he considered stage 1 cases. He gave 30 cycle of HBO therapy, okay, and examined the exposed bone. If it start healing, then he gave another 10 cycle of HBO therapy and termed it as stage 1 responder. But some cases do not respond to it. Then he put them in stage 2. Okay, in this he did the surgery, he removed the inferior border of the mandible and the lateral cortical plate and give 10 cycles of HBO therapy. If the patient respond to this treatment, okay, healing bone was seen and this was termed as stage 3 responder. If the patient still not respond to this treatment, then what was done is excision of the non-viable bone was done, that is segmental resection was done. Fixation of the mandible was done with reconstruction plate and another 10 cycles of hyperbaric oxygen therapy was done. Okay, and then you can say our patient was called after 3 months and then a reconstruction was done in that case. In case of cutaneous fistula, pathological fracture and resorption of the inferior border, these were directly put into the third stage surgery. Now, reconstruction can be done with pedicle flap because this increases the blood supply to the area. Or microvascular reconstruction with free fibula can be done because it also increases the vascularity. And after you have done the reconstruction and the healing is satisfactory, bone is viable, you could start with implant placement after 6 months to 1 year. With this, I would like to conclude by saying that osteomyelitis is no longer a relic of our past, rather it's a reality that animates and informs the presence about the increased number of cases refractory to standard treatment. At the same time, osteoradionecrosis should be prevented with proper education of the patient and proper communication between the radiologist and the surgeon to achieve an optimum oral health of the patient.